All right, welcome everyone to day two of the Clinical Research Ethics Symposium. I'm gonna give it, I was gonna give it to 10:32 to let everyone come in, but I see that our numbers are looking strong and the waiting room's quieting down, so I think we can get started. My name, if you remember me, if you remember me from yesterday, my name's Hannah Jones Erickson, and I am the manager for Research Ethics BC at Health Research BC. I'm excited to welcome you to session 3, day 2 of the Clinical Research Ethics Symposium. If you've been with us so far, welcome back. If you're just joining today, welcome. We're excited to have you here for our panel discussion with clinical research coordinators and managers. So I'll start us off today with a land acknowledgement. I've got my 2 feet planted on the ground, and I'd like to acknowledge today that I'm coming. Oh, sorry, I have my 2 feet planted on the ground, and I always look to my cedar tree, but my curtains are closed today, but I can picture it in my mind. I'm calling in today from the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'd like to acknowledge that as a provincial organization, Health Research BC's work extends across many Indigenous lands and territories throughout British Columbia. And we saw that reflected yesterday in the diverse areas that our speakers are calling in from. And we'll see this again today with each of our panelists calling in from a different location across the province. Yesterday, Alec Dan expressed gratitude for everyone coming together to learn and reflect and further this work and their work and all the work that we do. He'll be back at the end of today's session to close us off in a good way. I'd like to continue this gratitude and thank you all for your active participation yesterday, scintillating discussions, and active chat. And I'd like to thank you as well and express gratitude for you showing up today and for your excitement and curiosity as we launch into our third and final session. One of the themes that emerged when we were working on pulling together the agenda was this concept of implementation, the impact of climate change on study implementation, implementing ethics on the ground from the researcher's perspective, implementing changes in guidance and how to go about doing that and what's coming down the pipeline. But one of the emerging themes that I'm also seeing as we're going through all these topics is this focus on adaptation, responsiveness, paying close attention, thinking things through. And I'm really excited to see how this gets expressed. No pressure, speakers, but we'll see. We'll see if this continues into our third session today and the riff on that theme. So with all that, I'll move into some housekeeping. So this is it. This is session 3, last session on our second day of the Clinical Research Ethics Symposium. You'll notice if you're joining for the first time that we are on a Zoom call. This was a conscious decision by the advisory committee, our planning committee, who advised on planning this session to foster like a lot of engagement and communication and a real openness and sense of community as we go through our symposium. So with that in mind, if you have any questions or comments, please feel free to put them in the chat. If you'd like to ask a question directly to one of our panelists, we encourage you to do so, and you're welcome to raise your hand and our moderator will call on you. Otherwise, we'll ask that you stay on mute just to help keep the background noise down, and we'll be monitoring to help ensure that happens. If you need to reach any of the Research Ethics BC team, we have our backgrounds. You can message us directly in the chat, or you can send an email to researchethicsbc@healthresearchbc.ca. And with that, I'm going to turn it over to Sarah Flan. Sarah Flan has graciously agreed to moderate for us today. She has an MSc and is a research ethics coordinator, sorry, Sarah, with the UBC Clinical Research Ethics Board. Prior to joining the CREB, she worked as a research ethics administrator for Fraser Health Authority, as well as Adler University, Vancouver. Sarah also has over a decade of experience managing research in teams in the area of clinical neuroscience and neuroimaging. I just discovered we have another theme with our moderators, a focus on neuroscience. In her spare time, you can usually find Sarah roller skating or watching her kids' hockey and basketball games. Over to you, Sarah.
Thank you, Hannah, for the warm introduction, and thank you to the Planning Committee for what has been an amazing symposium so far, and I promise today will not disappoint. I'm joining from the township of Langley, which is situated on the traditional and unceded territories of the Coast Salish people, specifically the Kwantlen, Katzie, Matsqui, and Semiahmoo First Nations. I'm grateful for the opportunity to be with you today to explore the fundamental role of clinical research coordinators within the research ecosystem. Research coordinators are the frontline superheroes of clinical trials. Their role is essential to the success of any given trial from inception to completion. They perform a wide range of specialized, intricate, and complex tasks to uphold the integrity of clinical research. They are the personification of the ethical values central to the work that we all do. Without their dedication and expertise, clinical research simply would not be possible. We are very fortunate to be joined by a fantastic panel of clinical research coordinators who will share their insights into clinical trials from diverse perspectives. We'll start off hearing from Gail Carney and Sheila Bizet from Island Health, who will share their experiences managing different types of consent in clinical trials. Then we'll hear from Dustin McKay at BC Cancer Prince George, who will delve into the realities of running clinical trials in remote and rural regions of our province. To round out our session, Ali Hossani from Fraser Health will share the importance of considering cultural and linguistic barriers to clinical trial participation. Thank you to those of you who have submitted questions in advance of today's session. We'll also be taking live questions from the chat, and there will be time for questions after each panel's presentation, as well as a full panel discussion at the end. So for our first peek behind the curtain of clinical trials, I'm very excited to introduce our panelists. Gail Carney, clinical nurse educator for the research department at Island Health, entered the healthcare field as a registered nurse 20 years ago after completing her Bachelor's of Science at UVic. Her bedside nursing career spanned 12 years with positions in general medicine, cardiac medicine, and finally intensive care for the last 9 years. Fortunately, she was working in ICU where clinical trials were being conducted and became very interested in that work. She was she was excited to step into the research nurse coordinator position when the opportunity became available. In her spare time, Gail enjoys gardening, knitting, skiing hopefully soon, and spending much time with her grandkids as possible. We've also had a change in panelists. Deborah Parvet, clinical manager for research department at Island Health, was unexpectedly unavailable to join us today. Deborah, we wish you well. We are very lucky that Sheila Bizet has graciously agreed to step in and join our panel. Sheila is a clinical research nurse coordinator at Royal Jubilee Hospital and has been nursing since 1985, predominantly in community palliative care in the UK, Canada, Australia, and New Zealand, as a clinical nurse specialist and as a manager. Sheila entered clinical research in 2016 in the UK, working in hematology trials, which was a great transition from palliative care. She returned to Canada after decades away in 2020 and was lucky enough to join Island Health clinical research team working in dementia studies. In her spare time, Sheila enjoys overseas travel, yoga, kayaking, and exploring the wonderful island paradise that she currently calls home. Gail and Sheila, I'm turning it over to you for your presentation, One Type Does Not Fit All, Informed Consent Challenges.
Thank you very much. She will start.
Okay, so good morning.
Oh,
There we
That's
go.
even better.
There we are.
Good morning. Technical difficulty there. My name is Sheila Bassett. I am a research nurse coordinator at the Clinical Research Unit at Island Health. With me today is Gail Carney, our clinical nurse educator. Gail and I have both worked as clinical research nurse coordinators for many years, which is where our insights into conducting informed consent have come from. We are sharing our experiences of conducting different types of consent discussions in the hope that it will foster better understanding of one aspect of the clinical research coordinator's job.
Okay, one moment.
Technical difficulties?
There we go.
Hang on. I'm sorry, I know it's early, but I still think this is a martini glass with 3 olives, but anyhow. The factors considering when determining which type of consents are appropriate for the clinical trial are as follows: the type of intervention, or in some cases, no intervention, the risk involved, which can range from none to moderate to unknown, the population engaged in the research, whether it's dementia, pediatrics, or critically ill participants, the setting the research is happening within, whether it be the clinic, the emergency department, or community. There are sponsor versus rep requirements. The study coordinator needs to ascertain what types of consents will be needed based on their knowledge of the local rep. This may differ from the sponsor's initial task. One example of this is when the sponsor is adding a consent line regarding future research optional samples into the main consent form, as happens on my dementia studies, but knowing rep requests a separate future research consent form to be made. Next slide. As research coordinators, when we are initially preparing a rep submission, the majority of work lies within informed consent forms. Study coordinators and members of the REB should be working towards the same goal, which is having a consent form that is understandable, one that contains all pertinent information from the study protocol, and then one that isn't so long that the potential participant is overwhelmed with all the information provided and so just skims over it. Today, we are going to speak about the various types of informed consent forms with the rationale for their uses and the challenges each type of consent form presents. We will discuss waived, deferred, substitute decision maker, parent guardian, assent, patient partner, and a priori. First on the list is waived or no consent requested. This type of consent is used for data collection, chart reviews, and for broad interventions where one arm of the trial is not riskier than the other. The research coordinator's job is to provide enough information to the REB so that the agreement can be reached that this is the appropriate type of consent to use on the study. Waiving consent is taken seriously and most often only used if the above criteria are met. Next one. Waived consent does not mean uninformed. For example, the CLIC study that we used was a study conducted to examine if the type of intravenous flush used would influence the amount of complications experienced with central venous lines. These are large lines, IV lines, that are used in the intensive care unit. During this study, all participants were given an information letter containing details of the study, and they could ask for their data to be removed from the database if they wished. In our ICU unit, not one of the participants nor their family asked for the data to be removed from the study. With unit-wide trials such as this, the interventions are done as a blanket approach, and the participant may be subject to interventions whether they agree for the data to be collected or not. This concept can lead to questions amongst the staff working in the ICU. An important aspect of the research coordinator's role is to educate the staff and address these concerns they may have. We also need to ensure that they know the details of the study risks and benefits to participants and the future state of knowledge for ICU care. We also ensure that they're also aware of the research ethics review process and approval.
So next up is deferred consent. Deferred consent is used in low-risk trials, which require timely interventions, and consent is requested from the participant after the intervention has occurred. The main concept I would like to emphasize about deferred consent is that it is not in lieu of consent. In my experience, we have asked for deferred consent for ICU studies that are looking at interventions that are hypothesized to make small differences in patient outcomes, but are not yet proven. Often questioning interventions that are always done, but not necessarily the best way. These studies need large enrollment numbers to prove any difference between the groups, to prove whether there's an increased benefit or risk to either arm of the study. Either way, the difference is often very small, but in the ICU or emergency room, the small improvements these studies have uncovered over the last decades have added up to much better overall care. A key component of the hypothesis usually involves a very short time periods from the patient presenting with the problem and an intervention being applied. Often the question is about early intervention or timely intervention. For example, with sepsis, a severe life-threatening complication of infection, research has proven that early intervention makes a big difference in improved patient outcome and lowering death rates. Research has guided the sepsis protocols worldwide. However, this type of research cannot happen with traditional informed consent process. Timing is crucial. This is the Tri-Council policy statement that we use to guide us when discussing our request for deferred consent in our REB application. We always cover all of the points of this statement when we are requesting it, but one of the most important points to me personally is E. We make great efforts to connect with the participants who have enrolled with deferred consent. We have to wait until they are able to comprehend the study and ensure they understand their participation in the study, and that they recognize that they are given an option in the consent to have their information incorporated into the study or not. We often review the participants' progress and their recovery over many days and weeks to wait for them to regain their decision-making capacity after a severe illness in order to speak with us, read a consent form, understand what they are being asked to consent to. I've follow people in their journeys for weeks to ensure we have a proper discussion. This can involve many conversations with bedside nurses caring for them, reviewing care team notes, and conversations with the participants to assess their current state. Illnesses serious enough to require ICU admission often take months and sometimes years to physically, mentally, and emotionally recover from. These conversations are often very positive, but occasionally start off awkward. As a research coordinator, we have the responsibility to ensure every participant understands what the study is about and their role in it. We are often asked many questions, and interestingly enough, in my experience, often more questions than we are asked if we use a substitute decision maker. Very rarely do people object by the end of our conversations. They usually are quite happy to have participated. A good example of our use of deferred consent in our ICU here is the Lovett trial. The main objective of this study is to determine whether intravenous vitamin C compared to placebo reduces the morbidity and mortality of sepsis. The Lovett trial gave us very valuable information. In our ICU, the physician team, as with many around the world, were at odds with each other as to whether or not vitamin C treatment should be given to people with sepsis. Therefore, in our ICU, patients received vitamin C as part of their sepsis treatment, depending on which physician was working the day they were admitted. There were many small studies completed, one of which showed almost a miraculous recovery from such a simple intervention. So it was an enticing treatment to try, and it appeared harmless. The Lovett trial was conducted in Canada and New Zealand and France at 35 hospitals from November 2018 to April 2021. And we enrolled 872 participants in these centers. 10 of these were from Victoria. Most of the participants were enrolled with deferred consent, unless a substitute decision maker was at the bedside right when they arrived in ICU. And in reality, most ICU admissions are not planned. And it takes the time to locate family or for family to arrive at bedside because they usually have to travel. The study could not have been done without deferred consent due to tight time frames. The first dose of vitamin C had to be given within hours of the participant starting on norepinephrine, which is a blood pressure stabilizing medication used during sepsis, and that is often started in emergency. So they've already been on this medication before we even see them in the ICU. So it was very essential that we got our timing correct and that we had enough time to start the trial. This graphic of the Lovett trial shows that there was a very small difference between the two groups. And in fact, 3 more patients survived the non-vitamin C group per 100 than the vitamin C group. So it was a statistically significant enough difference for us to change practice. In our ICU and in ICUs across Canada and around the world now, vitamin C is no longer given to people with sepsis. So substitute decision maker. Not all the sponsors request a substitute decision makers, but we often ask for one anyways. Most of our studies, it seems to be quite helpful. Where it is necessary, or where participants may not initially have capacity or where capacity may decrease during the course of the study. For example, in our cognitive health dementia studies, we anticipate that there will be cognitive decline. So we always try and involve a substitute decision maker from the start. These assessments are done, or the patient or participants' assessments are done by the investigators and the research coordinators to determine if there is capacity to consent, and if not, we have to document well why we think not. The assessments must be done prior to obtaining consent and engaging a substitute decision maker. When obtaining consent via a substitute decision maker, the research staff must be sure they are speaking with the appropriate person and document how they determine this. Not in my research capacity, but in my ICU nurse capacity, I recently, or not recently, in the past cared for a person in our ICU. He was there for over 2 weeks, unconscious and being treated. And when he finally woke up, we found out that the person making the decisions was no longer in a relationship with this person, and he was quite upset that she had been making the decisions. So we have to really, really work at making sure we have correct substitute decision makers in care and in research. And it can be quite difficult in some instances.
Okay. Now, birth to 19 years of age is an extraordinary wide age range. Changes in physical and mental development during this time period are the greatest of any we experience. Requesting a child's autonomy and ability to decide for themselves must be balanced with ensuring all who need to be informed are informed. In BC, there's no legislation that has been interpreted as restricting children with the capacity to consent from consenting to research. If consent is being obtained from a person under the age of 19, it is the responsibility of the research team to ensure the person fully understands and is capable to make the decision. In reality, unless there's compelling reason to not include a parent, i.e. birth control with teens research, we always have joint parent participant consent discussions. Our pediatric research coordinator describes the difficulty of these conversations, during which he has to maintain the attention of a teenager reviewing a 28-page consent form. Good luck with that. However, in some situations, parental agreement may be appropriate or necessary. For example, research conducted within a school board must follow the policies of the school board, which in most cases require parental consent. Written assent is obtained for pediatric studies and dementia studies when consent is obtained by a guardian, or a substitute decision maker. These are the formal assent requirements. However, in the day-to-day conducting of research coordinators obtain assent verbally all the way through the study. We ensure the participant is able to express their willingness to continue to participate to the best of their ability. When Gail worked as a research coordinator in the ICU, she spoke with participants who were heavily sedated to let them know that what we were doing and why. Often the family were also at the bedside, and she had assent discussions with the substitute decision maker as well. When obtaining blood samples with longer-term dementia study participants, I always ask them if it's okay with them to do so. An adamant pulling away by the participant will be taken as a no. A challenge identified with written assent forms is how different levels of comprehension we need when the participant may be declining mentally over time, or a pediatric trial when the age range is 7 to 11. Written assents are not used in Island Health because of length for the cognitive health studies. There's really no point. An adult with cognitive difficulty who cannot consent for themselves is overwhelmed by a multi-page assent document, even if it's been reduced down to a 6 or 7 page document. Assents with children need to be suitable for the age of the child, both for content and language level, but also for maturity levels. This is an example of how we have adapted visuals for the assents for 12 to 13-year-olds and 14 to 17-year-olds, and the sections discussing interactions with the study team to be more in line with what the maturity level is. The research coordinator who works in our pediatric trials also wanted to share that he always makes sure the children understand the blue highlighted paragraph. It is utmost importance to us that the children understand they can change their minds at any time. In fact, it is highlighted in the assent forms as well.
Okay, so patient partners. Not all research requires this, but many do. Our dementia research relies heavily on the participants' partners to bring the participants to the office or hospital visits, to monitor drug compliance, to help with surveys, and to complete their own surveys as the partners. We have participant partner consent forms outlining all the expectations of the partners and review these extensively with them prior to enrollment. The dementia studies truly are a group effort. However, we also have participants in drug studies whose partners may not be included in the initial consent discussion at all. But we also ask the participant to ensure their partners understand that during the course of the study, they are asked not to cause or undertake a pregnancy. We cover the birth control requirements in the main consent form signed by the participants, but there's no separate consent form for these partners to sign at enrollment. But if a pregnancy were to occur, we ask the partner to consent to have the pregnancy followed by the research team. As a research coordinator, we prefer to include the partner in the initial discussion, but it is entirely up to the participant. And then the tried and true, a priori. It can be used with all interventions. It can be used for, definitely should be used for higher risk and longer consents. All cognitively intact adults, we use this consent. It's nice so you can go review this in the office, at home, in the hospital. And hopefully we're heading online. I'm sure that that's where a lot of our consenting will end up. And the time frame is as much time as it's required to fully understand, as long as it falls within the realm of the study parameters. However, there is problems with this consent form. It sounds like it covers it all, but it's covering it all a little bit too well these days. It's getting too long. It's longer and longer and longer. And I think we've heard it throughout this or in other conversations already. Our consent forms, our standard consent forms, are over 20 pages long. The language in the consent form is becoming more complicated. Even at a grade 7 to 9 reading level, the concepts are becoming more complicated. And the legalese is there. I've been given the feedback many times that the consent forms appear to be covering our legal liability rather than informing our participants, and that is a problem. We need to find a way to ensure information is conveyed in ways that informs and to the benefit of the participant, not us. Several groups are working on this problem. The Canadian Institute of Health Research Ethics Office and the Canadian Critical Care Trials Group are currently working on a project to create a standardized template for informed consent form, which hopefully will address some of these issues. And the FDA has a draft guidance advocating for the use of key information section at the start of the consent form. And I attended a webinar about that, and I just wanted to share a bit of that information. The FDA has a key information 2-page format suggestion for the start of the consent form. And I feel that, yes, it is adding 2 more pages onto the consent form. So it is problematic in that way. However, I think that as a group, we can keep it to 2 pages and keep it as the key points that can be referred to for more detail later or into the document, that it would really, really help with the informed consent discussions. The suggested FDA suggestions are voluntary, making sure that the voluntary participation is in there, and right to discontinue is in there. Purpose for the research, key risk and discomforts, but not necessarily all of them. Potential benefits, expected time commitments, compensation, alternate treatments available, the costs, if there are any, to the participant, and any additional information. The issues I can already see coming up with this is the discussion around what information should be in there, what are the key points, and what can be put later on in the consent form. It will definitely open a lot of discussion in that regard. And hopefully, as a group, we can keep it down to 2 pages. And if anyone wants more information about it, I put that slide up there so that you can find that out. It is online now. And they suggest this bubble format as a well-researched format that will guide people's attention and eyes into the different sections. And that is it for our conversation.
Great. Thank you so much. That was really interesting. You guys have really kind of run the gamut of different types of consenting procedures. From your perspective, is there an alteration from traditional consenting that you found to be the most useful? I know you work with a lot of different populations, so it might depend, but is there something that you kind of say, why can't we do this for everyone?
It's a varying population that makes that a little bit harder to answer, because you know, we are from children to very elderly people. I think that the traditional consent form, I think that what we're going to do, I think as a group, hopefully, is try to have that incorporating the summary pages in is our next step to try and see if we can make a more comprehensive, readable consent form. The only problem with that is that for something like our dementia trial, we really do want to make sure that everybody has read every page. So it still will require that in-depth discussion. So even if we use summary pages, we have to ensure that people are reading the whole document. So I don't know if there is an easy, better way to get consent, but I think that we have to try and find a way that will inform people more. And that's where I think we're going with the 2-pager.
So we do have a question from the group. So what they asked, what do you think about the idea of a 1-page consent? Having consented many participants using many methods, do you think this would actually achieve truly informed consent?
No,
I don't at all.
I don't think you could put it into one
One
page.
page, no.
No.
Yeah, it definitely sounds like also the really important piece is the communication between the team and the participant or their loved ones. We do have another question from the group. They noted it's very interesting to see that sometimes you can't find SDMs available. So in your discussion about the patient whose SDM was out of date, this is reflecting back to yesterday's session. What did you think about the practicality of advanced consent and needing to check if the existing consent given sometimes for basic things like who the SDM is can be wrong?
It would be along the lines of advanced directives. It would be somebody anticipating that they're going to need it would have to put it in. So for something like an ICU, like I said, nobody ever thinks they're going to end up in an ICU tomorrow. Like that's unless it's a planned, really complicated surgery. All of the people in the ICU are there by some unforeseen event.
Yeah.
It's never a planned thing.
But
so it'd be hard.
It would be hard but for the dementia patients,
Yeah.
a lot of them do have advanced directives already. And so that might be a little bit easier.
It would make sense to put something like that in
It
an
would.
advanced directive, or have it a suggestion for our geriatric teams to maybe discuss with people when they're seeing them, if they want to be considering research, like at the very early conversations.
I'm curious if you guys have noticed over your time working in this space, if if it's more common for people to have specific advanced directives to participate or not participate in research. And I'm thinking also like when you go to do studies with waivers of consent, is this something that you're seeing at all or not so much?
I've never seen it.
Never seen it.
No.
But with,
Okay.
I think with our dementia studies, we have a permission to contact for research, and we have a huge database of people who've signed that. So we can contact them regarding research. So they've signed that maybe 2-3 years ahead of time.
Great. Okay, so we do have more questions, but in the interest of time, we're going to table those to the end when we all come back together to discuss it.
Sure. Look forward to it. And I
Thank
need to
you so
stop
much.
sharing. Yes.
Thank you for the enlightening discussion. And we're going to turn over to Dustin McKay, Clinical Trials Nurse Coordinator at BC Cancer Prince George Center for the North. Dustin grew up in northern rural community of Fort Nelson, BC. He started working as a registered nurse at BC Cancer in Prince George in 2017. Over the last 6 years, he's trained in multiple departments, including systemic therapy, radiation therapy, pain and symptom management, and clinical trials. He completed a BC Research Challenge project looking at patients' experience of witnessing the ringing of the celebratory bell while receiving cancer treatment. He has completed extra accreditation with the Canadian Nursing Association, specifically training in oncology. He currently works as a clinical trials nurse coordinator, having helped open the first systemic chemotherapy study available to Northern BC patients in Prince George. Dustin, thank you so much for joining us. Cancer Trials in Northern British Columbia. I'm now going to turn it over to you.
Thank you for the kind introduction. So I'm going to be presenting on BC Cancer Trials in Northern British Columbia today. Next slide, please. I have the privilege to get to live, work, and play on the traditional lands and unceded territory of the Lheidli T'enneh people. Next Next slide, please. I have no disclosures, but as mentioned in my introduction, I will mention that I do have a bit of a bias for this presentation as I was born and raised in the northern community of Fort Nelson, BC. It's in the top right-hand corner of the map, and I'll show you guys a map here in a second. It's the home of the Fort Nelson First Nations, and I often get to speak about my hometown to northern patients at BC Cancer. It helps me create a quick bond and develop a therapeutic relationship with this group, and it's the reason why I chose to pick the case study participant to be from Fort Nelson in my presentation. Next slide. The topics I'm going to be covering today include clinical trials should be the focus and a standard of care that we offer, the geography and population of northern BC. I have a case study looking at a rural clinical trial participant, some real-time data and graphs I'm going to share with you, and how BC Cancer Prince George supports these participants and the community oncology network sites across the north. Next slide, please. So standard of care at BC Cancer, we believe that being able to offer clinical trials should be viewed as the standard of care. Supporting clinical trials in northern BC offers unique challenges. However, we should continue to improve access to these trials, especially being a center that offers clinical trials that improve care. It's improving care for all patients and not just clinical trials patients by offering clinical trials. There's been several studies that have demonstrated that there's been improved care for everybody for centers that offer clinical trials. One of the major challenges that this population faces, though, is a geographical challenge, particularly in northern BC. A majority of the clinical trials require participants to stay at the center or make frequent trips to the center that's offering the clinical trial. The appointments for a trial can range in a variety of activities where it's just a quick blood draw. Maybe they have to do a physical exam with the provider, get a set of vitals done, a height, a weight, complete endless amounts of questionnaires, maybe do some arm measurements. And sometimes it's really just can be a very quick appointment ranging from anywhere from 5 minutes to a few hours where they have to come to the center. I'm going to run through a case study that demonstrates why geography should be considered when offering clinical trials to this patient population and how we can support them to reduce the burden on these participants. Next slide, please. So this is a map of the BC. You can see in the top right-hand corner is Fort Nelson that I was mentioning with the red dot, and in the more central area, there's a star there for Prince George, where I'm calling from now. It is crucial to understand the size of BC to be able to offer these trials to the northern BC patients. It's a huge area with a population of just over 300,000 people over a landmass of 600,000 square kilometers. And for reference, I put a picture of France, which is just over 547,000 square kilometers. So we have a big landmass. For my case study, I'd like to introduce you to a 65-year-old woman from the rural community of Fort Nelson, BC. She was recently diagnosed with breast cancer. You can see that she lives up in the top right-hand corner there. Traveling for tests and procedures is not new for her cancer journey thus far in her diagnosis. Since her initial abnormal mammogram that she had just over 3 months ago, she's already had to make 2 trips to Fort St. John. The community of Fort St. John is 380 kilometers south from Fort Nelson, approximately a 3-hour and 45-minute drive on clean summer roads. If you add in bad winter road conditions, it can easily increase the length of the drive by an hour, if not a couple hours. And it can be quite scary, honestly. I've done it many times. She drove for the biopsy after she discovered the abnormality on her mammogram. And then 2 weeks after that appointment in Fort St. John, she had to come back for her lumpectomy surgery and a sentinel lymph node biopsy. Fort St. John is the closest community to her that offers these surgical services. After her surgery, her next appointment is a consultation with the medical oncologist from Vancouver via virtual health appointment done by Zoom. That's one positive that has happened with since COVID, is that we have increased our capacity, and being the center for the North, we do have a lot of experience with virtual health, and it's something that we are able to offer for these patients. The medical oncologist from Vancouver confirmed that she has a stage 3 breast cancer, meaning it's localized to her breast and regional lymph nodes in her armpit. She is able to be treated with hormone therapy alone, and she doesn't require any chemotherapy, but she does need to speak to a radiation oncologist regarding radiation therapy. She's appreciative to know that she doesn't require chemotherapy, particularly because Fort Nelson doesn't have a community oncology network site to offer this treatment to her. She would be driving again to Fort Nelson or have to maybe go to a different community if she has friends or family to get the chemo if she did require it. On average, this patient population with breast cancer, if they did need chemotherapy, can range up to 6 months and 8 rounds of treatment every 3 weeks. Next slide, please. So radiation therapy in Prince George, I'm going to speak to the clinical trial reel that this case study has offered and some of the options for this participant and the experience of consenting it and things that should be considered. So during the Zoom appointment with the radiation oncologist, it was recommended that she come to Prince George for 3 weeks of radiation treatment. Prince George is the closest of the currently 6 BC cancer centers that offer radiation treatment in the province. And they discussed that she was eligible for this clinical trial called REAL, naming being a randomized trial of hypofractionated local regional radiotherapy in breast cancer and lymphedema. She could be randomized to one of 2 treatment arms in this trial. Arm 1 is delivering radiation in a shorter time frame. It's the experimental arm with higher doses of radiation over 5 days, and arm 2 is the standard of care radiation treatment offered over 15 days. The study is looking to determine if the side effects from the shorter dose radiation to the axilla, the armpit, increases lymphedema and if they're worsened. For context, radiation treatments are delivered Monday to Friday, and we are closed on the weekends here in Prince George. And depending on their situation, sometimes patients from these communities will travel back home on the weekends, or they'll choose to stay in Prince George over the weekend if their treatments are longer than just the 1 week. As a nurse coordinator, I have multiple considerations before I'm discussing consenting the patient on the trial and after it was introduced by the doctor, including but not limited to when are they booked to be coming to Prince George? I know they're going to have to come here for a CT scan to plan the radiation. How can we best provide them with the information and consent form for them to better understand the study? We know that they need at least 24 hours to review the consent form before they're going to be choosing to make a decision to participate in the study per good clinical practice. Things to consider are, what is their internet access like? Do they have internet access? Do they have an email? Are they comfortable using the internet for me to send this consent form to them? Are they comfortable reviewing an electronic copy of the ICF? And can they consent virtually? So am I able to send them a Zoom link call if they have good internet access for us to connect? And then can they take a picture, or do they have access to someone in their community, a clinic, where they could then scan it or fax it back to me? It's interesting because just last week I was consenting a patient that was from one of the northern communities, and we had planned to schedule the consent on a Thursday afternoon because she knew her power was going to be off Wednesday. And when we were talking and did the consenting on the Thursday afternoon, the consent discussion went well, the Zoom was fine, but when she went to go scan a consent form back to me, she lost power, so I only received 1 of the 13 pages for the consent form. So it definitely happens, and it's a real consideration for this population. I need to ensure that she understands all the things that are involved with the clinical trial. Does she understand the randomization of the trial, that it's like flipping a coin? She's not automatically going to be selected for the shorter treatment arm, and it will be random. She'll be asked to come to Prince George for appointments to complete arm measurements and questionnaires compared to non-trials patients that may not have to complete these extra appointments and wouldn't have to do the arm measurements. The real clinical trial would be asking her to come from Fort Nelson back to Prince George for follow-up assessments to look for those side effects, specifically completing arm measurements, where we would look at her at the baseline, but in 1 year's time and then 3 years' time after that. And we would have extra follow-up appointments virtually with her for year 4 and year 5 of the study. It may seem like a bit much to ask participants to travel 8 hours to Prince George so we can measure the circumference of the arms and see how high that they can raise them up like this. However, lymphedema is one of the main study outcomes, and it's important that the arm measurements are done as accurately as possible and that the side effects are documented accurately as well. If she chose to not participate in the trial, she could be discharged back to follow up with her family doctor after a couple years for continued surveillance. On study, she'll be asked to complete 5 questionnaires, sometimes 6, depending on the timeline, at her baseline visit, that the last week of her radiation treatment visit, 3 months after her radiation treatment, in follow-up for year 1, 2, and 3. Some participants do find comfort in this extended follow-up that a trial can offer, though, and they don't always view this as a negative or a burden, but it is just something to realize that these would be extra trips for them to consider. There's a nuance to these conversations as well when discussing the trial with someone living in a rural or remote community, such as the lady from Fort Nelson. It's important to that the participant understands the follow-up for the study can only be completed in Prince George for many of the tasks, which is a big ask. And unfortunately, this study does not offer reimbursement for time or for travel costs. Some participants have feelings of wanting to be able to help others and be feeling obligated to help the researcher that may be offering the trial, and they may be thinking about the future of other cancer patients that may derive benefit from these trial findings. And it's important to recognize these feelings and ensure that they're not taking any undue burden onto themselves in order to help others or feel like they need to help the researcher offering the trial. I'm sure this eagerness to help is not unique to our patient population, and the other coordinators see this as well. It is important, though, for this patient population, particularly when we know that time for this population can be limited, maybe not this specific case study, but in many others. Some cancer trials participants' lives may be counted hopefully in years, but sometimes it's months or even weeks. They are selfless acts, such as another trip to Prince George for an exam or taking another call from a nurse coordinator to complete a questionnaire over the phone, is a benefit to the future of all cancer care patients. And we do thank them for it. Next slide, please. So this case study is not an isolated example. Many patients travel long distances in northern BC to receive treatment and still choose to participate in clinical trials. This data comes from our real-time clinical informatics platform, where we log trial participant information and we put their area codes. And you can see that some of the purple dots, each of the purple dots on the map, you can see are trial participants. There's a larger purple dot where you can see Prince George would be located because that's predominantly most of our participants are from. So it's a larger dot, but the small dots indicate that there's at least one or a few participants throughout the province. And you can see that there's some lower purple dots in the Lower Mainland and Interior Health, and on the island just indicates that a participant may have signed up for a study in northern BC and Prince George, and then they moved to another location or were transferred to another location, so we transfer that data. The green bar on this graph represents participants who have traveled less than 50 kilometers to come to Prince George for their trial. The blue is 50 to 200 kilometers, yellow is 200 to 500 kilometers, and the light blue is those who've traveled over 700 kilometers to get to Prince George and they participated in a clinical trial. Breaking that down into the percentages, you can see approximately 46% of northern BC trial participants for BC Cancer travel within 50 kilometers to Prince George. 29 or 15% travel 15 to 200 kilometers, and that number jumps up to 24% or 47 people who traveled between 200 to 500 kilometers, and a whopping 7.9% or 15 participants have traveled over 700 kilometers and have participated in a clinical trial with us, which is pretty crazy to think about. Next slide, please. This similar slide shows the graphs for Prince George and Kelowna, Vancouver Island, and the Lower Mainland, and you can see a comparison between the distances traveled by participants who are on Vancouver Island and in the Lower Mainland. And again, these are all BC Cancer trials or studies. For the Lower Mainland, 95% of their participants travel within 200 kilometers to get to the treating center, and less than 2.2% of their patient population, compared to our 14, travel more than 700 kilometers. Some of these patients will be traveling from the north to participate in trials that may be open in Vancouver or on the island or in the interior to participate in the trials. But again, they are traveling long distances because they often have to do certain study tasks in Vancouver that can only be done there. Next slide, please. BC Cancer Prince George. This is a picture of Centre for the North, where I'm calling from you guys now. It's a provincial and national leader in decentralized clinical trials, meaning that our trial work is done outside of our primary center. In Prince George, we've been working towards advocating for trial patients to be able to do some of their follow-up appointments and complete some of these assessments in their home communities. Prince George Research Unit is relatively young, and in an effort to further decentralize our clinical trials, we have opened up the first systemic therapy study to BC Cancer patients that's delivered in Prince George, and we work as a satellite site for Vancouver. We've been able to open that, and it is specific to the Prince George patients and those in Quesnel and Vanderhoof as well. So it's something that we're continuing to work and grow on to be able to offer it to a wider range of northern patients, but it is a start for sure. And we've just recently opened up our second chemotherapy study for prostate cancer patients for Prince George. We're working on training to support the community oncology sites, Terrace and Fort St. John specifically, for one of our studies that also has arm measurements, and hoping to help support the nurses so they can help patients that are on this breast cancer trial complete those arm measurements in Terrace or Fort St. John, so they're not being asked to come to Prince George just so we can measure their arms. We have multiple trials also at Centre for the North that look at de-escalation of treatment, which is exciting. Without going into detail of each trial, in essence, these trials are to try and determine if in some way can we decrease the amount or the length of treatments being offered to the patients, just to see if it provides the same or better outcomes for them, hopefully saving time for future patients. Northern BC trial participants are valuable. Their answers to their many questionnaires and outcomes in the studies provide evidence-based research to inform the side effects and treatment timelines for future patients. So hopefully in a few years' time, it will be the standard of care for the next stage 3 breast cancer patient diagnosed in Fort Nelson to only have to come to Prince George for 1 week of radiation treatment instead of the standard 3 right now. Next slide, please. How we support our patients. So there are a few ways that we're able to support these participants. And one of them is trying to be the most efficient and succinct coordinator as possible. So knowing that if a patient is going to be coming from Terrace or Fort Nelson or an outlying community, can I complete everything as much as possible in this 1 appointment time when they're going to be traveling to Prince George, making sure everything is going to fit within the timeline, because these clinical trials usually have many different asks and certain requirements. It's important that you're making sure that everything that can and should be done in that 1 appointment, and not having to hopefully have to call them and say something else needs to be done, or come back to Prince George because we forgot something. It rarely happens, but it's something that we do need to be cognizant of. Other ways we support them, it's discuss with patients before signing consent that they are agreeing to these follow-up visits and that they're going to come back to see us in Prince George, but there's never any opportunity. We're never going to be making them feel bad or guilty for not being able to attend an appointment. Participating in a clinical trial is always voluntary, no matter what point of the timeline for these participants. And we don't want them driving on dangerous or icy roads if it's unsafe to get here. And we try to complete as much of those trial tasks virtually as possible. And if we need to, we'll write a protocol deviation as needed. We offer trials, we offer referrals, to our patient and family counseling services, which is really awesome that we have out of Prince George, to see if there is any funding or support that may be offered to them, such as gas cards, food, and accommodations. There's a patient comfort fund that can sometimes help this population. And we're fortunate to have the Coeur d'Alene Lodge, which offers housing and meals for out-of-town patients at a very reasonable daily rate. And it's located right beside our cancer center here in Prince George, excuse me. And we also work with the Canadian Cancer Trials Network on the CRAFT initiative, which is the Canadian Remote Access Framework for Clinical Trials. This organization helps support clinical trials units to be able to enable participation in clinical trials for patients who live far from healthcare sites where the trial is primarily offered. So offered in Prince George, but how do we support those patients that are out in Fort Nelson or Terrace and other communities? We've helped and paid for clinical trials training for one of the family doctors who specializes in oncology out in Terrace. They are a GPO at their con site, the Community Oncology Network site, and it allows for patients that are on one of our COMET-3 trials to complete their follow-up appointments in Terrace and saving them from having to take trips to Prince George. And we're always continuing to brainstorm ways to reduce the burden of trials on participants. as we open new studies and continue to follow up on already open ones, we're continuing to try and improve our services and support for the Northern BC population. And while offering trials in the North can be challenging, it should be the standard. Thank you very much.
Thank you, Dustin. That was very interesting to hear the great lengths that participants go to help with clinical trials. We do have a question from the chat. The question is, what is the training provided for the R measurements? Are there any specific educational requirements in order to measure accurately, for example, through a trained lymphedema specialist?
There is specific training requirements that the sponsor will give us and provide for us to complete. We have a couple trials now that do our measurements. The technicalities with both of them are slightly different than the other, but essentially once you've done one, you kind of understand the aspects of completing the other. And then you've signed off that you've been trained, read the information provided. And the investigators, if you're new to the trial, they usually have experience with it as well. So they can provide on-hands training, and then we'll train other coordinators that come as well. It's not a lymphedema specialist exactly, but there is a finesse and technique to it. I will say I've measured people's arms multiple times, 3 or 4 times, just to make sure that I'm getting it accurate.
Great, thanks, Dustin. We do have other questions that we're going to save for the end. So we're going to take our final peek behind the curtain of clinical trials and hear from Ali Hassani, Clinical Research Coordinator at Fraser Health. Ali is a certified clinical research professional with over a decade of experience in academic and hospital-based research. He has coordinated clinical trials spanning various therapeutic areas, including nephrology, cardiology, critical care, and infectious diseases. Currently at Fraser Health, Ali manages observational studies and randomized controlled trials across multiple phases at Surrey Memorial Hospital. As a member of N2 Public Engagement Committee, he contributes to advancing equity, diversity, and inclusion in clinical research. Ali is dedicated to fostering an inclusive research environment where diversity drives innovation and enhances the quality and accessibility of healthcare. Ali, we now look forward to hearing from you on your perspectives on cultural and language challenges in clinical trials.
Hello, hi everyone. Thanks, Sarah, for the warm introduction, and thanks so much everyone for being here today. As someone who's been involved in clinical research for some time, I witness how language and cultural differences often discourage people from participating in clinical trials. And this is frustrating because these barriers limit diversity and prevent us from achieving truly inclusive research. That's why I wanted to talk about this today with so many of you here, especially REB members and ethics community folks. This feels like a perfect chance to highlight these challenges and discuss how we can address them. But before that, next slide, please. Before that, I wanted to recognize that I'm privileged to live and work in Coquitlam, the traditional and ancestral and unceded shared territories of Coetzee, Coquitlam, the Musqueam, Squamish, and Tsleil-Waututh First Nations, and home of the Golden Ears Métis Society. Next slide. To give you some background on this discussion, I want to start with a question. Have you ever thought about how much our health depends on the research that is inclusive of everyone? Clinical trials are the foundation of new medical breakthroughs, but if they only reflect a narrow segment of the population, can we really trust the result to work for everyone? This is why today's topic is so important. We're here to talk about diversity and inclusion in clinical trials, because while progress has been made, there are still too many gaps to fill. For instance, millions of people are excluded from clinical trials because of barriers like language, geography, or even lack of trust in the process. And I think Dustin case study was a great one, mentioning some of those barriers for patients. These barriers don't just hurt the individuals, they hurt science. We can't find solutions for everyone if our research doesn't include everyone. So for today, we'll focus on identifying the challenges and discovering strategies to build clinical trials that are truly inclusive. And we'll explore how to break them down, build trust, and ensure that clinical trials reflect the people it is meant to serve. And so for today, the main objective for my presentation, these are the main objectives for my presentation. And at the end of the day, we know that improving diversity in trials is not just an ethical obligation. It is the only way to ensure the better health outcomes for everyone in our community. Next slide, please. Let's take a moment to think about the barriers that prevent diverse participation in clinical trials. These are real and deeply rooted, but understanding them is our first step towards a meaningful and actual change. So on the next slides, we'll dig deeper into some of these challenges. Next slide. So as we begin to unpack the challenges, here are some key barriers that often stand in the way of inclusive clinical trials. Language barriers can prevent people from fully understanding and engaging. Second is cultural sensitivity. It's another hurdle, as not all the trials design consider diverse lived experiences. And then there's therapeutic misconception, where participants may think a trial is a guaranteed treatment for their condition. And access inequities and lack of resources, like transportation or childcare, at another layer of exclusion. And finally, diverse health literacy level. That means that not everyone has the same knowledge and ability to process or act on their health information. So recognizing these barriers is the first step towards breaking them down, hopefully. Next slide, please. Language barriers are one of the biggest challenges in making clinical trials accessible to everyone. Imagine being asked to make an important decision about your health, but the information is in a language that you don't fully understand, or even worse, it is presented in a way that doesn't fit your cultural perspective. For many people, for many patients, this is the reality. When trials or trials materials aren't available in multiple languages, or aren't culturally relevant, participation becomes really impossible for those who might benefit from it. And even when they want to participate, a lack of multilingual staff can make this communication frustrating and confusing for them. And one of the examples can be informed consent. Informed consent is not about just signing a piece of paper. It's about making sure participants truly understand what they're signing up for, and the risk, benefits, and what the trial involves. And without a clear communication, we risk not only losing their trust, but also compromising the ethical foundation of the research. Next slide, please. The second challenge on my list is the cultural sensitivity. We should realize that it is about more than just understanding. It's about designing trials that honestly reflect the realities and needs of the communities that we're trying to serve. When trial designs do not account for cultural differences, we risk isolating participants and losing critical perspectives. For example, a study might exclude people by failing to respect religious practices or dietary restrictions or family structures that influence their healthcare decisions. This lack of awareness creates a barrier to trust and participation. And there is a deeper issue, and that's historical mistrust. Many communities, especially racial and ethnic minorities, have experienced systemic discriminations in healthcare and research. This reminds me of the Tuskegee syphilis study as a well-known example that caused lasting mistrust in the medical community. mostly among African Americans. This study was involved observing untreated syphilis patients without informing them or providing treatment to them even after penicillin became the standard treatment. These past wrongdoings have left scars, traumatized communities, and consequently made those communities highly cautious about participating in clinical trials. Obviously, rebuilding the trust is not something that we can do overnight, but what we can do is to show our genuine cultural respect and sensitivity in every step of our research process. Next slide. So another challenge in clinical trials is the concept known as a therapeutic misconception. This happens when participants by mistake believe that joining a clinical trials is the same as receiving guaranteed treatment for their condition. It's understandable when they're facing a health crisis, the hope for a solution can lead to expectations that don't match the purpose of the research. And as we all know, the clinical trials are not designed to guarantee individual treatment, but they're meant to test new drugs or interventions for safety and effectiveness. And sometimes participants fail to realize that they could be randomized into placebo or control group, or even the study medication itself is still experimental. If we don't explain this clearly, we risk creating false hope, which can lead to disappointment, mistrust, or even disengagement when participants realize that the trial is not what they expected. Next slide. So access inequities is another major roadblock in making clinical trials inclusive. Let's think a little bit more about this. Like an example that Dustin used. For example, people living in rural areas or underserved communities, often they face significant challenge just to get to the clinic or a trial site. For some, it's distance. For others, it's the cost of travel, missing work, or arranging a childcare. These are practical barriers that can be ignored. Then there is technology. Remote and virtual trials might sound like a solution, but they can also leave people out. As Dustin mentioned about like power outage. So many people don't have reliable internet, the right devices, or comfortable level with technology to participate. And this can unintentionally exclude those who may already be underserved. And finally, we can talk about community engagement. Too often, there's not enough effort to fully connect with the communities that we want to include. And community engagement really means listening to their needs, addressing their concerns, and meeting them where they are. Without this, the gap between the people we hope to recruit and those who will participate in our studies keeps getting wider. Next slide. Another topic that can really influence participation in clinical trials is health literacy. Let's start with medical terminology. In healthcare, we often overlook how technical our language can be. For example, terms like placebo or adverse events might be clear to us, but for someone without a healthcare background, it can be overwhelming. Although informed consent is intended to empower participants, for those with limited health literacy, it feels more like a test designed for them to fail. If the consent form is filled with jargons or presented in a way that's hard to understand, participants may feel hesitant to sign. And there is an issue around engagement and retention. It's not enough to only recruit someone into a trial. It's also important that we ensure that they feel supported throughout the study. Next slide, please. Okay, so these are just a few challenges, and the list could go on as we go deeper into the topic. But given our time for today's meeting, let's shift to focus on solution. Next slide. So although there are various stakeholders in clinical research, including sponsor, researchers, and regulatory agencies, and each can play a role in overcoming these challenges that we discussed. But since this is an ethics-oriented symposium, I'll focus on the role of ethics boards, or REBs, and see how they can help to address some of these challenges we've discussed. REBs have a unique responsibility in reviewing and approving trials, and they have this significant opportunity to make a difference. First, they're able to ensure recruitment plan is inclusive and communication is clear, and so make sure that it's not just putting out a flyer or sending an email. And recruitment is about meeting people where they are and in a ways that they understand. And it's about making sure the process doesn't feel intimidating or out of reach for patients. And secondly, they can also push for culturally sensitive practices. And although there's been some progress, but to be honest, there is a lot of work still needs to be done in this area. And trials are sometimes designed without considering the beliefs or traditions of the people being asked to participate. And thirdly, the ethics board is there to ask these questions as from the sponsor researchers. Have you thought about how this will be received by the communities you're engaging or you're recruiting from? And number 4 is trust. And that's a big one because mistrust didn't just appear out of nowhere. It's rooted in history, in harm done by the healthcare system. And REBs can step in to make sure the trials are transparent and don't repeat the past mistakes. They can ask the hard questions about fairness and ethics. And finally, they can help with keeping equity front and center. They can ensure communities aren't just afterthought in these studies. This could mean providing feedback, ensuring resources are distributed fairly, or just encouraging a deeper connection between the researchers and participants. Next slide. Okay, so let's talk about inclusive recruitment. It's about making sure clinical trials represent everyone, especially groups that often left out, like racial and ethnic minorities, rural or low-income communities, people with disabilities, or older adults. We need targeted strategies that address real barriers. As we mentioned in the previous slides, for some, it's practical challenges like transportation or work schedules. For others, it's about rebuilding the trust, especially in communities with a history of mistreatment in research. Once we truly understand why, we can define how and tailor our strategy for including them. Another thing we might need to think about is our eligibility criteria. Sometimes without realizing, we create rules and exclude people who could benefit from or add value to the study. Can we broaden participation without losing scientific accuracy? If yes, then we need to find ways to reassess our eligibility criteria. And partnerships are key factors in our success in everything we just talked about. Community groups like faith organizations or local nonprofits, they already have a trust of these communities. And we can work with them very closely. We can build connections and improve our communications with them and show that participants' voices and experiences truly matter to us. Next slide. To promote culturally sensitive practices, we can focus on 3 main things. First, clear and inclusive communication would help. It's not enough to just share information. We must ensure it's understandable and relevant to the communities that we're working with. That might mean using plain language, avoiding medical jargon, and ensuring materials that are culturally relevant and translated when needed. And secondly, we need to bring cultural perspective into the design of the studies. Every community has its own unique experience and values that shape how they view healthcare. By incorporating this perspective, we're not only respecting their realities, but we're also improving the relevance and effectiveness of the trial. And finally, we can equip our research teams with the tools that they need to succeed. An example can be cultural sensitivity training. When teams understand and respect the cultural background of the participants, they build trust, and that trust is essential for encouraging participation and ensuring the success of the study. Next slide, please. So building trust means being transparent from beginning. That could be clear and honest outreach strategies to make sure people understand how the study is designed and why it matters. We can invite and involve communities even in the protocol development process. When the people affected by the research have a voice, it shows respect for their experience and helps create studies that are more relevant and meaningful to them. And let's not forget, trust isn't a one-time thing. It's something that we have to maintain throughout the entire study. This involves rigorous ethical standards and ongoing monitoring. So we're not just checking boxes, but we're truly protecting the well-being and dignity of every participant. And trust has to be built step by step, and it requires constant effort to keep. Next one, please. And I realized that I've been emphasizing on the importance of engagement, communication, and community outreach throughout this presentation. And it might feel like I'm repeating myself, but the reason that I keep coming back to these is that they are the base of everything that we're discussing. So let's slightly shift the focus and talk about the outcomes of our efforts and outreach. Let's ask these questions: how we can ensure that all the work that we're putting into engaging with diverse population actually works and can make real and tangible changes. This is where data becomes essential. Are we keeping track of who's participating in our trials? Are we making progress in including underserved groups, or the same gaps still persist? Monitoring equity means putting systems in place to measure progress and identify gaps. It's about looking at the numbers, but also listening to the lived experiences of participants. Are they being treated with dignity? Are their concerns being addressed? It's not just about opening the door for everyone to participate, but making sure that the space we created for them is truly equitable and inclusive. Next slide, please. Okay, let's wrap up with some key takeaways. First, addressing cultural and language barriers is not just about doing the right thing, it's about ensuring the success and integrity of clinical trials. When we fail to address these barriers, we not only risk excluding valuable voices, but we also compromising the quality and relevance of the research itself. So strategies like fostering community engagement, utilizing professional translation services, and providing cultural training can have a deep impact. There aren't just checkboxes. They're tools to build diversity, trust, and understanding. And as we discussed, the role of Research Ethics Board, or REBs, can't be overstated. They are critical in maintaining ethical practices and ensuring equity remains at the front throughout the research process. And eventually, this work is about more than just the clinical trials. It's about equity, trust, and making sure research truly serves the diverse communities that it is meant to benefit. So I'll just stop here and thank you everyone for being part of this discussion today. Thank you. Next slide.
Thank you so much, Ellie. That was really wonderful and a lot of food for thought. So I do have questions for you, but given the time, we're going to take a quick 5-minute bio break, and then I'll start off with your questions when we come back for the group discussion. So if everybody wanted to stretch out and get a refreshment of your drink or go to the washroom, now's the time. Please rejoin the session at 11:57. Thank you. All right, welcome back, everyone. Thank you to all of our panelists. We've got lots of questions that have been given to us, and I'm really hoping we have a chance to address them all. Ali, I'd like to start with you. We have a question regarding the issues of language barriers. So many studies only are asked to face the issue of language barriers during the REB review. They fail to build in costs of translation into their design. How can researchers be encouraged to build translation into their budgets? Oh, I'm not sure if I'm on.
Oh, sorry, I was in
Oh.
mute.
Sorry, I'm not sure if everybody, did you hear that, Ali? I wasn't sure if we were back.
Yeah, it's working for me. I can hear you. Yeah.
Great, great. So for those just joining us back, the question was that in regards to that, many studies are only asked to face the issue of language barriers at the REB stage, and it fails to build the costs into translation into the study design. How can researchers be encouraged to build translation into their budgets?
Yeah, so definitely depends on the trial, and unfortunately, we see for many trials that they ignore that part, that which communities that we're recruiting from, and I think REB can require them or basically encourage them, or researchers or the PIs themselves, because they know their patient population better than the others, so they can basically request that budget as something that is going to affect the study significantly to recruit from. Because excluding people only because of the language that is happening for some studies, I think that's one of the barriers, and it's going to affect the basically the ethical inclusivity of the trials.
Great. And in your role as a coordinator, do you feel that sponsors and researchers are getting better at incorporating diverse input into their studies? And have you been able to push back where needed? That question was for Ali as well.
Sure, yeah. So I think we see a trend of EDI or EDIA, equity, diversity, inclusion, and accessibility become a trend. I see FDA has drafted a guide for researchers that they can use that and implement more of those in their studies, and also Health Canada, to follow the FDA, they also drafted a guide for researchers. So this is something I think it's coming, and it's really important, and that's great that everyone realized that we need to do more of this, and we need basically major improvement in this area to include everyone in our research, and that's great that we see that that's coming up.
Thank you, Ali. Similarly, Dustin, have you noticed improvements from sponsors and funders to help support remote participants to partake in your research over the years?
I don't have as much experience having the back and forth with REB and sponsor communication, but it has been definitely mentioned by REB that something that they're considering, that the sponsor should be considering, and how you can provide further funding and support. And I think it is part of the role too, that they push for that and ask from these study sponsors to make sure it's something they are considering.
Thank you. So Gail and Sheila, over to you guys. We're curious how you navigate situations similar to what Dustin mentioned, where the REB might flag something and the sponsors got a different perspective on how things are supposed to, you're kind of in the middle. So how do you negotiate those situations?
I guess it depends on what the situation is. Unlike Dustin and Ali, like with rural communities, the dementia studies are industry related, so there is money for travel costs and that sort of thing, because I'll have patients that are way up island in Camel River, that sort of thing. But if not, we do try to negotiate with the sponsors. Generally, they're large pharmaceutical companies. There is money there, so we have that on our side to do that.
Great. So this question's for all of you. Are there particular sections in the consent form that participants typically have a harder time understanding? So in your experience with each of your populations, is there kind of a sticking point where they're not quite sure what you mean? Maybe we'll start again with Gail and Sheila.
Mhm. I'd say by and large, the privacy language is something that we really have a harder
That's
time
true.
with, because lots of people don't understand why we're discussing it. So part of the discussion is why we're discussing it as well. And that's been mine. A lot of conversations around what we're going to do with the data. It's very difficult to make that into a real easy concept, and so there's a lot of discussion about what happens with data. And so the conversations tend to get quite long and quite technical, but you have to still try and make sure at the end of the day that you're doing the active listening and active conversation and making sure that you're getting the feedback that people actually understand what they're agreeing to. So it takes a lot of experience and practice to have these conversations with people.
To reassure their fears that, when they're concerned where their data is going overseas, and in this day and age, it's getting more out there. And people are more aware of discrepancies in their privacy and their data. That's actually a talk that even my dementia patients, that's the number one thing they will talk about. And they're concerned about.
Dustin, I see you nodding vigorously over there. Is that similar experience that you've had?
Very similar. That's the exact, I'd say, one of the more sticking points, and it's either they don't even have the question to ask about what are you explaining to me and why is this pertinent? How does it, particularly in cancer care, which has been my experience, is like, well, we just having that understanding, like, this is why we're explaining it to you, and this what these 2 pages are explaining, and the paragraphs are going into detail about de-identifying your data and how that works, and the translational arms of the studies, and why researchers may also be asking you to do a blood draw for this portion of the study, and how that aspect of the study actually, well, we need to discuss how they could have access to your information and what information is always usually a point where they seem to have quite a bit of interest and they have an idea about it, or you can kind of see that they glaze over and they're hoping that you're just skipping to the next page. So you're not having to go into too much detail with them.
Ollie, I'm curious about your experience in the context of accessibility for culturally diverse and language diverse populations. And you did also touch on that there are some tools. So if there's any tools that you could share with the group to refer us to, that would be great.
Sure, yeah, just going back to the ICF, I also see like those concerns from the patients, especially around the risk, and that's great. The REB asked us to list the risk of treatments, like even like revealing the percentage of each risk. But sometimes basically communicating that risk to the patients, it's sort of hard for us as a clinical coordinators. So it would be great if a doctors, physicians, or someone from the clinical team can basically explain those to the patient. So one of the things, for example, a clinical trials that using anticoagulation, and definitely with using anticoagulation brings some risk and bleeding. And as soon as patients see those risks listed, there are lots of question mark. So it would be great if the PIs and physicians are basically involved in explaining those risks to the patients and kind of like explain to them the risk and benefit, so they can basically decide if they want to participate or not. And the other thing, the same thing as others mentioned, so the privacy, and also when the studies includes genetic testing, that's where like sometimes a lot of patients have lots of questions, what they're going to do with my sample, what kind of information they're getting from my DNA or samples. So that's another thing that we need to, as a coordinator, explain a lot to them, or sometimes we have to just ask the physician or the PI to basically step in and talk to them and really like clarify like what's going to happen with their samples and that genetic testing. And yeah, so what was the other question?
I was just curious what tools you've used that you found helpful with your population to help navigate these conversations. Do you have access to translation services, or is that study dependent? If there's any other documents or resources that you'd recommend people look into?
Sure, yeah. So being a part of N2 Public Engagement Committee, and that's a good basically a great discussion throughout Canada. Like we have committee members from different provinces, and we meet monthly, and then we talk about all these barriers, how we can address them. And for example, right now we're working on a FAQ document. So we're just actually working on all the kind of like questions or medical terms that patients are not clear about, and it's like consistent for all the studies. We're just working on that document, and hopefully we can make that available to everyone to use. So that's one of the tools. And also if folks can basically check the N2 public engagement website, there are some tools there. For example, there is a website, it's called, it starts with me. So on that website, we have some videos and basically some flyers or brochures explaining the different phases of clinical trials, and also one or two very interesting videos about pediatric clinical trials. So if happened that you work with like kids or pediatric population, that's really handy. They use some sort of cartoons and stuff that they can be used.
Great, that sounds fantastic. We'll have to look into those resources, and I see Pia is sharing some links and Hannah sharing some links in the chat for anyone who's interested. So we do have a question that was submitted in advance of the session, and we're curious as Research Ethics Board administrators, what, if any of you have had experience with the harmonized review process, and if you have any thoughts or comments that you'd like to share with the group on that.
I can say a few things. We have used the harmonized review process quite a bit. It works very well as long as everyone is communicating very very well. Like the people who are doing the initial submission for harmonization really need to take on the responsibility to communicate with the rest of the group, because we don't get included in the conversation unless they pass it on to us. So it's the way the system is currently set up. It is a little bit problematic in that way, that we don't have a real open communication about all kinds of things. Even like 3 years in, amendment will go in, and if the person putting the amendment in doesn't communicate that with you, you don't have any way of knowing. So it can be very problematic in that regard. Otherwise, it is nice. It's nice to work with other groups and find out what other groups are working on and how it's working in their institutions, and you can really learn a lot from each other on how to run studies and really hone it down well. We do it mainly with academic studies. I don't think we've ever done any industry studies harmonized. It's only academic. So it has definitely advantages in the connections, but it has disadvantages if the connections are not done well. So
Great. Ellie or Dustin, do you guys have any experience with the harmonized process?
Sure, yeah, that's a great thing to have here that we have in BC. It's essentially less work for coordinators if you're submitting in REB, if you're not the submitting site. So we can basically easily join the ethics, and that's great. And the only thing that we can always basically not harmonize, but all the ethics review is the lengthy process. And that's one of the challenges that we get lots of like pushing from the sponsors for the study to be activated. And if it's at this time of the year, like we're reaching the holidays and everyone's off work, so that's sometimes become a challenge for us to manage.
Thank you. So we do have a lot of questions. I do apologize to those who submitted questions that we didn't have an opportunity to discuss. Oh, I see from Hannah, we have time for one more question. So a general question for all of you is, what is your biggest barrier when it comes to the ethics review process?
Biggest barrier,
Time?
time.
Time.
It is. And you know, I think what Ali touched on is really key as well, is the communication back and forth.
Yeah.
Summer is another bad time. Summer and December months are really difficult because every time we make an adjustment or answer a question to Reb, we usually are wrapping in the sponsor into the conversation. Any consent changes have to go through the sponsor. So it's a lot of getting people to answer promptly so that we can get things rolling in a manner that is smooth is the most difficult part. And you're definitely the hub as the research coordinator between many different spokes that you have to have communicating with you in order to get that done correctly.
How about you, Dustin?
I would agree. Just to jump back to the last question and loop this question
Sure,
together is
yeah.
I applaud the initiative towards the harmonized approach. BC Cancer is lucky in that we do have a more harmonized system with the BC Cancer Research Ethics Board. So all the centers we can have been working on improving, being able to jump onto studies as well as industry studies that are opened up at other centers. But the communication is key, because it's saving that time for the research ethics application. And there's many different emails sending out from the primary center going, we're putting in a PAA, any changes, any concerns, anything that you need to be putting into. So there is that extra piece of work with the communication from the site that opens the study, but it does, I believe, save a lot of time. And overall, the work is spread out when you have more studies opening up.
And do you agree, Ali, with time, that being the largest factor for you?
Yeah, time and also I just wanted to, so another kind of like hurdle that we have submitting ethics is editing the consent form. And it comes with all different basically formats from the sponsor that are submitted to us. So although it's good that we have basically a guide, BC Common consent form, and we follow that guide step by step for each health authority, and that's perfect guide to follow. But it's still, like as I say, like we have this challenge that each sponsor like brings different format, and even when we try to use the guide to edit the informed consent, but it's still we get some like comments from the ethics definitely to revise more or more appropriately to the study. So that's one of the challenging task for coordinators that are submitting the ethics.
Absolutely, I could see that being the case. A question for anyone who wants to take this one on. Have you had any ethical issues raised to you by your participants that you would like to share with the group?
Can't think of any off the top of my head. No. Have you?
Not specifically. I think it's part of our role to be on the side of the participant that's making sure that they're participating and we're advocating for them. So I view it as if there is that kind of concern. Hopefully we've caught it and been able to address it first and making sure there's no burden onto them.
Yeah, I think the ethical review process is thorough, and we, by the time we get to the point that we're opening a study, I think we've covered most. Yeah, I don't think there's very many outstanding issues that can possibly be left to cover. Yeah.
I like to think not.
Yeah, I know. Yeah, hopefully not.
Ali, did you have anything to add?
No, same thing. I haven't heard anything specific from patients. Sometimes there are some complaints around like scheduling the visits, but not specifically on ethics issues. I haven't heard anything so far.
Well, that's quite reassuring. Maybe we're doing our job then. Hannah, do we have time for one more question? Just looking for Hannah. Yeah, one more. Okay.
Go for it, Sarah.
So another question that came up is how you prioritize which study you approach a potential participant with when you've got multiple studies on the go at once.
We did this a few years back. We had microbiologists working with us with FMT studies. And we had a couple of different studies on the go at the same time. And there was always little minor differences in the studies, and sometimes that channeled people into different groups. And if they were really suitable for both, we often presented both to the participants and said, if you'd like to choose which one, you can choose which one. And because there were slight differences in how many that would affect them more than us, like what visits there were and the timelines of the visits. So we had people choose that way by looking at the visit structure for those studies. But that worked quite smoothly. We had good enrollment in both of them and great outcomes. One of the products is already approved for use in the States, so. That's good.
Wow, that's great.
Yeah.
How
Yeah,
about
so
you?
pre-authorizing trials basically also depends on the deadline. So we try to make sure we meet those deadlines. For example, if it's CIHR funded and they like the researchers, they have a deadline to use that funding. So we just kind of like pre-authorize recruitment for that study. Over the study that we have is still like a year or 2 years to recruit. So
Trials
deadline.
sorry.
So, yeah.
Yeah, the Canadian Critical Care Trials Group that does ICU studies, they also allow a lot of co-enrollment in their studies. So we can enroll participants in more than one study at a time, as long as they're not conflicting.
Yeah.
Well, that's great.
I was just going to say we have similar, we'll reach out to the study sponsors to confirm that they'll allow co-enrollment. We have a symptom management trial that would be able to reach out for quite a few BC Cancer patients and participants, and maybe on another trial too. So we just confirm co-enrollment is a possibility. And we have 2 breast cancer trials that are pretty similar, but with trials, the criteria for enrollment is so specific. So we kind of start with the one that's more stringent and more difficult potentially to get into. So we offer that first if it is available for them, and then offer the second trial.
Great. Since you guys do have RIB members and administrators ears at the moment, could you each share what your #1 wish list item would be from us to help make your life easier?
My #1 wish would be that we could get a rev approval, I guess, a lot quicker for our dementia studies. And so we could be much more competitive with the American studies because they open up so much quicker.
It's like shorter consent forms.
Yeah,
I feel like we really need to work on that. And there are lots of groups working on it, but we really need to figure it out for participants' sake, mainly. Yeah.
I agree on that.
Yeah, so if I had to pick one, I would pick community engagement. It would be great if RIB can enforce researchers to basically do a little bit research before finalizing their protocol in terms of like recruiting which communities they're going to involve. So yeah, that's one thing I think is very important.
I'd push for easier process for online or virtual consenting process to make sure the sponsor has some plan or that meets RIB approval and protocols in place. So it's just easier to do that and make sure that it's part of the study for feasibility.
Great. Well, we'll take all that under consideration. Thank you guys all so much for joining us today. This has been super enlightening, and you all, like, your work is so important. So thank you for the work you do, and thank you for prioritizing your participants. I'm going to turn it back to Hannah to do our end of the day tidying up.
Thank you, Sarah, and thank you to all of our panelists today. Thank you for your engaging discussions. I'll just say, slight split focus, trying to make sure Alec Dan has the right link So hopefully he'll be joining us very soon. So I'll go, and then Rachel, Jessica, if you can assist with that in the background. So thank you everyone for the engaging and wonderful discussion today. Sheila and Gail, it was fantastic to hear like your detailed look at all the different types of consents and the benefits and drawbacks of each, and then the thoughtful reflections and experiences that you had there. Dustin, thank you for the very real snapshot of rural and remote research. I particularly loved the case study that really illuminated it for me. And while this has always been important, I know it's been on folks' minds recently, so it's very helpful and a timely presentation to have that detailed picture. Ali, thank you for the practical solutions that you offered at the end of your presentation for increasing diversity in research. And I look forward to see how these unfold in the future conversations. And thank you, Sarah, for moderating and for the fantastic discussion that you navigated us through at the end. So if there's any unanswered questions, we'll save the chat again. And if there's any unanswered questions, we can work with our speakers to get answers out to you there. We're going to put the evaluation survey into the chat. These events are for you, and we want to know what you think. And please complete, since this is our last session, we invite you to complete it if you've attended all three to help give the feedback on the whole of the symposium. I'd like to, while they aren't in the room with us right now, I'd like to extend a heartfelt thank you to all of our speakers for coming and sharing their passion with us over these past 2 days. Thank you to all of our moderators, Allison and Karen and Sarah, for supporting our speakers, facilitating the conversation, and helping shape each of these unique sessions. I'd also like to extend a heartfelt thank you to our planning committee, Dorothy Herbert, Karen Medler, Pia Gantz, Raman Kaur, and Sarah O'Shaughnessy. Thank you so much for helping us put on this event. I'd also like to extend a thank you to the Research Ethics BC team, Allison, Jessica, for the roles that you've played over the past 2 days, and then an extra special shout out to Rachel for everything that you've done to put this event on and making it all happen. I'd also, as my final note, like to extend an honorable mention to Clinical Trials BC. Thank you, Tatiana, Jean, and Rishi for, Jean for speaking, and then Tatiana and Rishi for opening up your community and bringing everyone together for these fantastic conversations. And those are all my notes. So I'll, did Alec Dan join while we were doing our wrap up? No? Apologies. This daycare cold is really sticking around. Well, Oh, I see. He's trying to enter the same meeting as yesterday. All right. Well, perhaps we'll work with them to develop something out and find a way to do an asynchronous closeout. I won't let you all hang out on the line while we do some tech troubles, but thank you everyone for attending, and have a great rest of your day.
I'm just keeping the meeting for a moment in case anyone needs
Oh
help.
no, here he is. Okay. We'll welcome him on. Ask him to close us out, and then maybe we can clip this and send it out to the participants.
Yeah.
Does that sound like a plan? All right.
Yeah, sounds good.
Hi, Alec, are you there?
Yes, I am.
Lovely to see you. Welcome back.
Yeah.
Now, I will say, unfortunately, with the little tech, we've had some folks filter off, but figured
Yeah.
we're still here. You can close us out. and we'll get a recording out to everyone who attended today. So we'll do an asynchronous closing.
Yeah, good afternoon, everyone. Thank you for asking me to be here with you this evening or this afternoon, sorry. To close your meeting off in a wonderful, good way. I hope everyone, was able to give their input, and again, to continue to be there for the community. It's always nice to share what my family elders asked of me was to really speak from the heart. It'll your words, your meaning, your purpose will get across in such a wonderful, good way. It's always yeah, that's just part of what we do in our cultural longhouse ceremonies, also as a MC for the host family, a speaker for the host family. We get to learn to really express our well, not ours, but the family, the host family's feelings, through the speaker, through the MC that's speaking on their behalf. So once again, I can't thank you enough for coming together, Natsamot Mistimo, having that one heart, one mind, and really taking care of the community. It's yeah, yeah. Yeah, it's I can't express that enough and can't thank you enough for coming together, being there for the communities, and your families, um throughout BC, and throughout the lands, I want to share our Seven Sisters honor song. The moral of this story and how this song come about us was at one time there were seven sisters with us, and they were no longer with us. Unfortunate, um deaths amongst them, and becoming ancestors, but they continued to be there for the community. They were reincarnated as old growth cedar trees, and getting to know us indigenous Coast Salish people, you really see how important the cedar tree is to us. Shelter, our big houses, our long houses, clothing, the cedar bark made into to cedar regalia, the natural oils, making it waterproof, and that becoming our rain gear during the winter months. Tools to go hunting and fishing and gather those wonderful natural resources and foods, and traditional medicines and traditional herbal teas to heal our body. So again, being there for the family, being there for the community, providing those few resources from the cedar tree, and the cedar boughs, the branches, part of a healing process, what we call our bathing ceremony, happening during the daybreak, up in the mountain with the mountain water, and the cedar boughs at sunrise, so that's when we take care of ourselves spiritually so we can continue on. So I'll share the song with you to thank you and honor you for once again coming together and having that Natsamat Mistimo, one heart, one mind, and so I'll sing the song. Aichkasim. Oh, 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 Share a little bit more about that song. Our seven sisters that were here with us, where they were reincarnated as old growth cedar trees and placed in our village called Swikwai. We know it as Lumberman's Arch today in Stanley Park in Vancouver, and it's so nice and cool. You know how we still provide for our people even though we're not here in human form, you know. And Geelt's the great transformer that reincarnated them, thought of them, how they could continue to be there for the community, because it was a really sad, heavy time when they were passing, becoming ancestors, and so yeah, it's awesome to hear, stories and wonderful things like that of our people. So thank you once again, for asking me to be here with you today, to share, a little bit of from the community, to share a little bit from the community of thanks and appreciation for the wonderful work that you all do. Thank you once again. Thank you.
Thank you, Alec. Thank you for closing us out, and lovely to see you again. I know you normally open for us, but it's fantastic to have the bookend. Yeah. And thanks as well for